Management of congenital hypertrophic pyloric stenosis. It occurs in 2.5 to in 1,000 infants. More common in the males, 4 times more common in than girls. It has some amount of familial predisposition. 10 to 20% of the cases has family history. So there can be genetic predisposition, syndromic association, and your maternal macrolides, erythromycin, and this erythromycin and others. They have a little bit of this sort of incidence. Exact mechanism is not known. And then how do they present? Usually non-bilous projectile vomiting, intermittent sort of vomiting, usually after food, and usually occurs in 7 days old infants to 5 months old children. So the late cases, yeah, it's possible in up to 2 to 8 years, but commonly the first week of life to 5th month of the life. So after vomiting, child feels hungry and he wants to have the feed, and then you have the vomiting. So you have the loss of your hydrogen ion, thereby you have alkalosis, raised bicarbonate. You have hypochloremia. These two are diagnostic, and then along with it, if you palpate the abdomen, you will have the your olive-shaped mass, 2 centimeters, around 1 inch or so, visible, palpable, and moving from the left to right. And if you do an ultrasound, which is diagnostic with 95% sensitivity, with pyloric canal thickness 3 to 4 millimeter, length 15 to 19 millimeter, and diameter 10 to 14 millimeter, is said to be diagnostic. So this is the way you diagnose congenital hypertrophic pyloric stenosis and exclude other differentials. Less commonly, you do the barium meal. Nowadays, not often used. The string sign, increased canal length, bulge, shoulder sign, and then your parallel, streaks of double track signs. They are not being nowadays done, not being seen nowadays. So differentially, naturally, reflux, gastroesophageal reflux disease, and your adrenogenital syndromes, metabolic acidosis, and then certainly the vomiting of acute watery diarrhea, and others like urinary tract infection. How do you treat congenital hypertrophic pyloric stenosis? When you diagnose it with certainty, you go for the Ramsted's pyloroplasty, pylorectomy, fluid electrolyte correction, and laparoscopic myotomy is also possible. What you do is you just relieve the muscles, constricting sort of things in the pylorus. And at times you can use the atropine as a muscle relaxant, which is not usually practiced globally. The Ramsted's pylorectomy is the usual practice throughout the globe.